Hi, I'd like to introduce Dr. Richard Libman, who has been with us a number of times. He always brings us very valuable information and what's new on the horizon for strokes. I would like to tell you a little bit about who he is. He is the Vice Chair of Neurology at LIJ Medical Center. He is the Chief of Vascular Neurology and Professor of Neurology at the Zucker School of Medicine at Hofstra Northwell. So good afternoon, Dr. Libman. I understand that you've got some new information about a new version of the TPA clot buster drug that is very exciting and coming into a lot better usage these days. So go take it away.
And thank you very much, Ginny, and hello to everyone. I hope everyone's doing well. And you are absolutely right. We've had TPA now since 1996 as the first proven effective treatment for stroke, as you know. And exactly as you said, it is the so-called clot-busting drug used very early, results in better outcomes for our stroke patients. As good as TPA is, there are a few what you might call minor disadvantages. One example of that is when we give TPA, we first want to just build up a certain level in the blood. So we give TPA quickly as a little injection over about a minute or so, and you just kind of inject it in. The trouble is that the amount of time that the drug lasts in the bloodstream is relatively short. And because of that, after you give that 1 minute injection of TPA, that's not going to hang around for too long. You want it to be around for a longer time. After you give that injection, you then have to attach an IV, and you then have to give the rest of the drug over an hour. And it has to go in a special way, very accurately in terms of the dose. And that means you just don't put it through a regular IV like running through a tube. You have to attach it to an electric pump. And the pump you set to deliver the drug at a very specific rate. And then you get the IV going, and it takes another hour to get the drug into the person or into the patient with stroke. And that presents all kinds of small problems that you may not think of. It's relatively simple if you're just sitting there and you're not going anywhere. But remember, a lot of our patients, after they get TPA, the clot-busting drug, may also be eligible to be transferred to one of the few centers here or there that do more aggressive treatment for stroke, where you put catheters right up into the person's brain, pull out blood clots. That's only done at certain selected centers, which are called comprehensive stroke centers. For example, there are a few in the Northwell system, which is a huge system, and there are a few around the state and, of course, around the country, but not many. Those specialized centers are few in number compared to all the other regular stroke centers. So I bring that up because now you've got the patient on this pump. Now they've got to be transferred into the ambulance. Sometimes the ambulance uses their own pumps. So you then have to take them off the pump from the hospital, re-hook them up to another pump in the ambulance. The ambulance brings them to a comprehensive stroke center, and guess what? That pump belongs to EMS, not to the receiving hospital, where you have to do the specialized procedure, switch the pump again. Each time running a small risk, you want to make sure that you've given the right amount. Every person along that step, those transitions, knows how much TPA has been given, how much is still to be given. You have to give the exact right dose. You have to make sure each of those pumps is working properly. Sounds so tedious and ridiculous, something that most people don't think of, and something I never brought up before, but I'm introducing it this way, obviously for a reason, which I'm going to tell you in a minute, because we now have a new TPA-like drug, which is like a first cousin, actually more like a twin brother, sister, almost an identical twin to TPA. And it's just designed a tiny bit differently. It looks almost the same when you see a picture of what TPA looks like under a microscope. Then you see a picture of what this new drug looks like. They look almost identical, but if you look very carefully, there's a molecule here or a molecule there with a slight little change that you would only see under a microscope. This new drug is called tenecteplase. Tenecteplase as opposed to alteplase. Alteplase is the general name for TPA. That is the TPA we've been using since 1996. Tenecteplase is this incredibly close relative of TPA. And it's very interesting. Why would we even think about it? And, how come it just cropped up? And why did we suddenly decide that this new TPA called tenecteplase might be an even better choice for our stroke patients? Like, where did it come from? Just like a jack in the box sort of popping out of nowhere. Well, in fact, it's not out of nowhere. It's very interesting. And to see where it came from, we have to look to our close colleagues in cardiology, where we frequently find inspiration because cardiology tends to be about 20 years ahead of neurology or neurovascular, stroke neurology. In general, our colleagues in cardiology have been doing things to treat heart attacks about 20 years sooner than we've been doing to treat brain attacks. If you go back about 20 years, go back to about the year 2000, actually, there's a drug called tenecteplase, which the cardiologists started to use to open up blocked blood vessels in the heart. And it was FDA approved at the time, and it's still FDA approved for the treatment of heart attacks. And it does quite a good job in opening up blocked blood vessels inside the heart. Why aren't the cardiologists using it even more frequently? The reason is that nowadays, cardiologists in general for emergencies will go in with a catheter, put a stent in your heart, and open up that blood vessel very, very quickly. And to a significant, but not a complete degree, but to a large degree, that kind of emergency stenting of heart attacks has taken over from clot-busting drugs. But there are patients still who can't necessarily get a stent immediately in their heart, and our colleagues in cardiology will still sometimes use tenecteplase, proven effective to open up heart blood vessels when you're in the middle of a heart attack, and quite safe. So it's been a couple of decades, believe it or not, and there were some investigators and scientists in the stroke world who started to think, maybe we should start looking at tenecteplase for stroke. Why? Why are we interested when we have TPA? Here's something that's very interesting about tenecteplase. It lasts a long time. So that as opposed to TPA, where you have to give a shot over about a minute, then additional IV over an hour, because there isn't enough that stays in your bloodstream to do the job. There isn't enough. That's why we have to give it over an hour to make sure that enough sort of hangs around in your bloodstream to ensure that the TPA has the desired effect. Tenecteplase, this relative of TPA that was used for heart attacks 20 years ago and still occasionally is, has a much longer lifespan in the bloodstream. So you can give it as a single injection, not even over a minute. You can actually give it over about 5 seconds. And because it lasts much longer in the blood, we no longer need to go through that tedious process of hooking a person with a stroke up to an electronic pump, make sure it's pumped into the bloodstream through the IV at a specific rate. Okay, and now you have to transfer this person because they need more aggressive treatment at a comprehensive stroke center. Oh, take them off the hospital pump, transfer them onto an EMS ambulance pump, get them over to the other hospital, take them off the pump. Remember, every time you make changes like that, you run the risk of a slight miscalculation. Is there a slight miscommunication? Oh, I'm sorry, I thought we had given half the dose of TPA. No, it actually was 3/4 of the dose. Well, hey, wait a second. I'm not saying that happens very often. It's actually very rare because we're dealing with professionals in the ambulance, et cetera, and the emergency departments, they know what they're doing. but everybody's human. So it's just introducing the possibility of error, not to mention the difficulties in transferring pumps and all that kind of thing. It's logistical. Suddenly we have this drug, tenecteplase, that has a much longer lifespan, and we give it as a 5-second injection, no pump, no nothing. Get that patient in the ambulance, get them over to the comprehensive stroke center, nothing more to worry about. So that's just one example of why people began to think, hey, this drug might have certain advantages over TPA. Then you could say, well, it is a little different. Is it as good as TPA? Is it as effective as TPA? Is it more effective than TPA? Is it as safe as TPA? Is it more dangerous than TPA? Is it, etc. So as a result, over the last 20 years, there've been a whole series of studies, mostly kind of small studies, mostly comparing this new TPA, tenecteplase, to regular TPA. And pretty much every single study shows that tenecteplase is at least as good. At least as good. Definitely not worse in terms of effectiveness. So now we have a drug that's easier to use because you can just inject it, no pumps, no IV infusions, etc. And virtually every single study has shown that it's at least as good. And guess what? In certain situations where you have a major stroke with a major blockage of a big blood vessel inside the head, not one of these small strokes, not even one of the medium-sized strokes, the biggest strokes where a major blood vessel is blocked, those are hard to reopen. That's why we have these catheter-based treatments where you go in with a catheter, pull out the clot, because we knew for all these years that TPA has a hard time opening up those big blockages because the clot's so big. It's just hard to get enough medicine in there to keep breaking it down without exposing the person to any risk of bleeding. Like, you only want to use the right dose. So we've known for a long time it's hard for TPA to open up those blockages. Guess what? 2 studies showed that tenecteplase is twice as effective as opening up these major blockages of the biggest blood vessels inside the head. Very often, we're still not successful. But if TPA can open up 10% of those blockages, we now know that tenecteplase opens up 20% of those blockages. So that's really nice. That's a big difference. It's true, a lot of patients will still remain with blocked blood vessels and they need the catheter-based procedure to pull out that clot. But now you've taken only 10% to 20%, which means that 1 in 5 of those patients, by the time they get to a comprehensive stroke center and would need that procedure, 1 in 5 will have opened up just with tenecteplase, blood flow restored, no longer need a procedure. Another advantage of tenecteplase, it opens up twice as many of those blood vessels. It finally, in these days of cost consciousness and cost-effective treatment, guess what? It's about 2/3 of the cost. It's about 30% less expensive than regular TPA. So every time you treat a patient, the hospital has saved a couple of $1,000s. So that's not the main impetus, but it just so happens, here's another plus. If we only have that so many dollars to go around for healthcare, and it's stroke and it's heart attacks and it's cancer and every other bad thing that can happen to people, if you can save a couple of $1,000s per treatment and not sacrifice anything in terms of treatment effectiveness, in fact, it's, as I said, at least as effective, and in certain circumstances, even more effective. And I forgot to mention safety. Every single study comparing tenecteplase to TPA has shown roughly equal safety. So you can't say that it's safer, but it's definitely not more dangerous. There's always a certain risk of producing bleeding in the brain. There's a small risk with TPA. There's the same small risk with tenecteplase. Every bit as safe. up to now, we had a whole bunch of usually small studies suggesting everything that I've just said, at least as effective, maybe more effective in certain circumstances, as safe as TPA, and easier to use and less expensive. And then finally, after a whole bunch of smaller studies, within the last May, June, July, five months or so, a very large study, one of the largest studies comparing tenecteplase to TPA was finally done. It was actually a Canadian study using multiple centers, and large, like close to 2,000 patients, which I can't tell you, like when it comes to stroke studies, you know, the average stroke study is a few hundred patients. The big studies for TPA from the NIH that proved the effectiveness of TPA, where LIJ was, you know, one of the major centers involved in the country, that had a total of 300 patients. It's so hard to get patients into these studies, and it's difficult to screen them and get informed consent. Remember, many patients with stroke are not able to give consent for studies. You have to get family. They can't talk. They're aphasic. They don't recognize what's wrong. All the things that stroke does to you, you can almost never get consent from the patient themselves, from the person themselves. You need it from family. It is darn hard. Here came along a Canadian study just about 5 months ago with, I think it was like 1,600 patients, head-to-head comparison, TPA versus tenecteplase, beyond the shadow of a doubt, showing that tenecteplase was every bit as good as TPA. Remember, we didn't have to show that it's better. We don't have to show it's better. Nobody expects it to be better. It's almost identical when you look at how it's made and the structure. No one expected it to be better, but it's at least as good. And if you have something that's at least as good, quite a bit easier to use because it's just 1 5-second shot and not the big infusion, not the big IV infusion for an hour, etc., for all the reasons that I described, less expensive, equally safe. The rules in medicine and science in general say, if you have an alternative, even if you can't show that it's better, you don't have to show that it's better. But if it's at least as good and it has other advantages, which tenecteplase does, everybody thinks that's a reasonable choice. So here we are with this new drug. And at Northwell, which is our big system, you know, 23 or so hospitals, we are now going to be making this transition within the next few months, wholesale transition, TPA to tenecteplase. Multiple other big stroke centers in the country have made the switch and are watching very carefully and collecting data on their patients. And it looks like in the real world, outside of scientific studies, the scientific results are being reflected in the real world. In other words, as you begin to treat people in real life, not as part of research studies, the results are equally good as were suggested in the scientific studies. India, as a country as a whole, with 1 billion people, has basically made the change nationwide to tenecteplase. Multiple centers in Australia, I think probably 2/3 of the country, has switched to tenecteplase. As I said, multiple centers in the United States, although that's a work in progress, but multiple big centers in the United States, like UCLA, some of the Harvard teaching hospitals and other big centers across the country have already made the change. Still many hospitals using TPA, and there's nothing wrong with that. So that's basically the story. And that's the latest in with respect to clot busting drugs for stroke, the switch from TPA to tenecteplase. Now, again, not to suggest that every hospital is doing it or has to do it. This isn't mandated by the FDA. It hasn't reached that stage where the FDA has said, oh, well, this is approved and this is, you must all make the change. We are not at that stage. We're at the stage where all the clinicians and all the stroke specialists are using their judgment and just saying, we think this is a good idea. So it's still a little bit catch as catch can. Whichever hospital happens to have this idea is now making the change. So that's the tenecteplase story.
Thank you, Dr. Libman. That was such a great update, and it's such good news. And I hopefully all of the hospitals eventually will get their acts together and get on board with this new drug. We're going to have you back in a little bit. We'll be talking about, I think, wake up strokes. So we look forward to another segment in a little while. And thank you very much.
Very good.